we turn our attention to the current state of affairs and what looks like the future in terms of the questions of management of ovarian cancer from the systemic perspective. Time would not allow me to cover all of the controversies, all of the unknowns, all of the uncertainties, all of the questions. They're massive and growing literally by the week with new reports. So ovarian cancer, remarkably, the core chemotherapy remains the same as it was 20, 25, even 30 years ago. Carboplatin and paclitaxel, obviously demonstrating just how good these drugs are. But that's where even anything you can call remotely certainty ends. And I'll just throw out these questions, and they're not answered. They're not answered by trials. They may be answered by opinions, but not by trials, and certainly not by any FDA or any other edict. What is the role of bevacizumab? And it's a massive role, and I'll come back to that. How many? 4, 5 plus phase 3 randomized trials looking at bevacizumab in ovarian cancer that have shown an impact on outcome, progression-free survival, which is the only relevant outcome that you can actually look at. Not that you can't show an improvement in overall survival, but because with all the secondary, third line, fourth line therapies available, it's virtually going to be very hard in the future to show an impact on overall survival. My point being, what about bevacizumab? What about the role of intraperitoneal therapy? Now, some of you may think that that particular question has been resolved. Let me assure you it has not, and I would refer you to commentaries that I've done with Oncology that have written about this, a completely unresolved question because of quite frankly, the problems with the trials, questions about bevacizumab. What about the role of neoadjuvant chemotherapy? When should it be used? When should it not be used? When should we use surgery? What about the role of PARPs in the management of the illness? Very complex. Multiple PARPs. How long should they be given? What are the potential side effects? What about the combination strategies? That is just questions in the frontline setting. In the second line setting, this question of 6 months, 12 months, platinum-sensitive resistant, doesn't make any sense anymore. And the answer of course it doesn't. Because with maintenance therapy, and particularly if you're using an agent like an anti-PARP, which acts very much like a platinum agent in some ways, would you go back to a platinum if a patient recurred? Maybe yes, maybe no. Where are the data to tell you and help you? We don't know. Again, the question of bevacizumab. I just need to emphasize that bevacizumab is a drug that has been completely and adequately explored in ovarian cancer. You might talk about individual trials, but the facts are that bevacizumab seems to potentiate the effects of perhaps all drugs we give. Not because it necessarily synergizes, but it might improve blood flow to the area, improve the ability for the drug to get there. How do we explore this? When do we use bevacizumab? When do we not use bevacizumab? Questions completely unanswered. What about the optimal sequence of therapy in ovarian cancer, which is increasingly becoming more of a chronic illness? It's less of a question today than of which drugs you'll give in the setting of recurrent disease, as to what sequence will you give them. And finally, there's this massive question about what about the routine role, in my opinion, we should consider it, of next-gen sequencing and the 1 to 2% of patients with ovarian cancer with a variety of abnormalities where there's now FDA approval. Should that be obtained on every patient? My opinion is yes. And if you have an abnormality, how do you particularly sequence that? We actually know, and studies have been done, that maybe only half of the patients that might or should have had basically next-gen sequencing actually have that done. And certainly even looking at questions of seeing if a patient has a BRCA mutation, maybe half of the patients get that. So if you don't do the testing, how do you know if PARPs might be relevant? It's not that doctors are not interested in having the information. They're simply overwhelmed. And we need to figure out how, in the case of ovarian cancer, how to get this information to the doctors so they can optimally care for patients. I thank you for your attention.